Good morning, good afternoon. Welcome, everyone. I am going to give a presentation on long-acting drugs for HIV treatment and prevention. This has become quite a complex and rich topic and will be difficult to cover in 20 minutes. So I'm going to show a number of slides where I won't have time to discuss the data, but a PDF copy of this presentation will be available after the conference for anyone who wishes to go and review the details. So let's begin. I'm going to talk first of all about long-acting Kabbategravir and long-acting rilpivirine. This drug combination is now approved in most of the Western world, approved in the United States this year in January. And so this product is now being used commercially in clinics in these countries. The activity of this two-drug combination has been quite robust, with 96-week data from several studies now showing that the two-drug long-acting regimen given every 4 weeks or every 8 weeks is non-inferior to standard daily oral combination antiretroviral therapy. In addition, this two-drug combination, despite large volume injections in the buttocks, has been quite well tolerated by those participating in the phase 3 studies, with most of the adverse reactions being mild and mostly reactions related to the injection site. In studies where participants were offered the ability to switch from every 4-week to every 8-week injection, the vast majority preferred using this two-drug combination every 8 weeks as opposed to every 4 weeks. And that's shown in this figure, where the dark blue of the circle represents those who prefer the every 8-week injection, and the purple is those who prefer the every 4-week. And as you can see, the vast majority would rather get these injections every 8 weeks, not surprisingly. Now, the one thing we still need to be concerned about with the two-drug combination of long-acting Kabbategravir and rilpivirine is that it is still possible to develop resistance to this regimen, even if you come and get your injections on time. And this is a table from an analysis that was presented last year, but was recently published, looking at the risk factors for treatment failure in patients on the Cabenuva registrational trials. And what you can see is that 4 factors were associated with a statistically significant increased risk of developing confirmed virologic failure, and 3 of those were baseline factors. One was the number of rilpivirine resistance-associated mutations at baseline. Second was the log of the 8-week rilpivirine trough concentration. Interestingly, not the Kabbategravir trough concentration. The baseline HIV viral subtype, being either A6 or A1, was a significant risk factor for treatment failure, as was the body mass index, with individuals being more overweight having a greater risk of treatment failure, although that risk was small, an odds ratio of only 1.13. Now, in addition to treatment, Kabbategravir has been used in prevention studies, and I'm going to quickly review those studies with you because I think those results are quite important. These are the primary outcome data from the HPTN 083 study. Beatrice Grinstein from Rio de Janeiro was one of the leaders of that study, which was published in the New England Journal of Medicine in July. In that study, the Kabbategravir arm as compared to the tenofovir M-tricytidine arm, was associated with about a threefold reduction in the risk of seroconversion in at-risk MSM as compared to the oral arm. And so this was a highly significant result, and perhaps a surprising result, that the injectable regimen was so much stronger at preventing HIV infection in at-risk MSM. A parallel study examined the same regimens in at-risk cisgender women. That study was conducted largely in sub-Saharan Africa. And similarly, that study showed a significant benefit of the injectable Kabbategravir regimen for PrEP as compared to the daily oral tenofovir M-tricytidine regimen. In this case, about a ninefold benefit of the injectable regimen compared to the oral regimen. Now, one of the surprises of this study was that there were treatment failures in some cases associated with drug resistance. And this is a figure from an article that this is data that was referenced in the July 2021 publication, but is examined more fully in a publication in March in the Journal of Clinical Infectious Diseases, looking at confirmed virologic failures of the injectable Kabbategravir regimen, and there were 13 of them. And interestingly, 5 of those failures occurred in individuals who reliably showed up for their every 8-week injections. And I think this has raised a number of important questions we unfortunately don't have time to delve into today. But it's important to keep in mind that when used for PrEP, for prevention, injectable Kabbategravir given every 8 weeks can lead to failure with infection and resistance, even in patients who get their injections on time. Right now, it's not completely clear why this is happening. There is some thought that this may be related in some cases to low drug concentrations. It may be the genetics of the infecting virus. It may be the nature of the exposure that led to the infection, or it may be something else. But this is an area I think we all need to pay attention to, despite keeping in mind the fact that Kabbategravir was substantially better for PrEP in men and women than daily oral tenofovir and M-tricytidine. Now, I want to leave Kabbategravir and rilpivirine now and move on to newer agents in development. And first, we're going to talk about the subcutaneous capsid inhibitor, formerly known as GS6207, now known as lenacapavir. This is a drug with a unique mechanism of action. It is a maturation inhibitor. It blocks the maturation of the HIV virus particles at several different stages, and as a consequence has a very high barrier to resistance. In addition, this molecule is quite potent. Resistant variants have low fitness, and the drug has excellent pharmacokinetic properties with a half-life of 30 to 43 days when given by injection. Both oral and subcutaneous formulations are in development, and both formulations have significant anti-HIV activity. And this is the results of the phase 1 study, looking at 4 different doses of lenacapavir and their ability to lower viral load by up to an average of 2.2 logs. This is the pharmacokinetic profile of this drug when given as a single subcutaneous injection in seronegative volunteers. And what you can see is that the 2 higher doses of 900 milligrams given either as 3 1 milliliter injections or 2 1.5 milliliter injections subcutaneously. Those 2 higher dose injections maintained plasma concentrations above the target, which was 6 times the inhibitory quotient for at least 6 months after a single injection. Now, the pharmacokinetics of this drug require an oral lead-in for the first 2 weeks, with 3 oral doses followed by every 6-month subcutaneous doses, and that is projected to maintain concentrations above the target indefinitely. A study of this drug in highly treatment-experienced patients was presented at CROI this year, showing that when Longacting was combined with an optimized background regimen, it was substantially more efficacious than a placebo combined with optimized background regimen. And these data have now been used to apply to the FDA in the United States for approval of Longacting for treatment of heavily treatment-experienced individuals. It is important to keep in mind, however, that these data are only out to 14 days and use the oral formulation, not the subcutaneous formulation. And the data on the efficacy of the subcutaneous formulation in this population has not yet been presented. Now I'm going to switch now from Longacting to talk about another new agent in development, Lactrovir. Lactrovir is an interesting drug. It is a nucleoside reverse transcriptase translocation inhibitor, an NNRTTI, that has multiple mechanisms of action. It does have a 3' hydroxyl group in the ribose ring, which means that it can, in theory, serve as a chain extender when incorporated into the HIV RNA-DNA duplex. But in fact, because of its chemical conformation, it acts as a chain termination drug after incorporation and inhibits translocation of the RNA-DNA replication complex. It's an interesting drug because it's being developed in several different formats. It has been approved in the United States as a once-daily oral drug in combination with doravirine, but it is also in development as an implant. And I'm going to talk now about implant formulations for Lactrovir. As you probably are all aware, we've been using implants for contraception for many years. And the Lactrovir implant uses the same format as the Nexplanon implant, which is an approved hormonal contraceptive. And this is a look at what that implant looks like, as well as simulated pharmacokinetics of this drug when given in this case, every once a week orally, as compared to the implant given administered for 120 days. Now, there are human data on the Lactrovir implant in various forms that have been presented as recently as CROI in 2021. And in this figure, you can see the actual pharmacokinetic data of a 56 milligram Lactrovir implant given to HIV seronegative volunteers for 12 weeks and then removed. And if you simulate from that 12-week pharmacokinetic curve, what would happen over a year, over 52 weeks, you can see that the active metabolite of Lactrovir, the intracellular triphosphate, maintains concentrations above the PrEP pharmacokinetic threshold of 0.05 picomoles per million cells for at least a year. And so this is very exciting data that suggests that a single Lactrovir implant could prevent HIV infection for at least 1 year. The safety and tolerability of the implant has been quite good, although there have been local reactions, as have also been seen with hormonal contraceptive implants. And so I think we need more data on the tolerability of these implants as the PrEP studies expand. In addition, Lactrovir is being developed as a long-acting oral drug. This is the design of a phase 2 study of Lactrovir for PrEP given once a month at 60 or 120 milligrams. And as I told you earlier, because this drug has an excellent pharmacokinetic profile, that allows it to be given once monthly for PrEP. In addition, Lactrovir is being developed once monthly as an oral drug for treatment in combination with this new drug, MK-8507, which is an NNRTI, non-nucleoside reverse transcriptase inhibitor. And that drug has been shown to have significant anti-HIV activity in 1-week monotherapy studies shown here. In addition, this drug has a half-life when given orally of about 70 hours, supporting its once-weekly dosing in combination with once-weekly Lactrovir. Now I'm going to switch to talk about intravenous long-acting antiretrovirals. And the representative of this class are broadly neutralizing monoclonal antibodies. This is the HIV envelope protein, showing a number of different monoclonal antibodies that neutralize the virus that are in clinical development. One of the interesting things about these antibodies is a simple 2 amino acid change in the Fc binding domain greatly extends their plasma pharmacokinetics. And this is a published study showing the pharmacokinetics of 2 different long-acting versions of broadly neutralizing antibodies, VRC07-LS and VRC01-LS, as compared to the unmodified VRC01, showing that these 2 antibodies maintain their target, maintain the concentrations above their target for at least 6 months after a single infusion. Now, these antibodies have been tested for PrEP, one of them, VRC01, given every 4 weeks in large studies conducted in South America, South Africa, and North America. And unfortunately, they did not meet their overall efficacy boundary when compared to placebo. However, in a sub-analysis, in areas where the virus was predicted to be sensitive to VRC01, they showed about a 79% overall reduction in the risk of infection, largely in cisgender women, but these studies also took place in MSM. And so if the virus to which the subject is exposed is sensitive to the antibody, they do appear to be effective for prevention, which has encouraged their further development for both prevention and treatment now in their long-acting formats. So that's a very broad and I'm afraid somewhat superficial overview of the current state of long-acting antiretrovirals for treatment and prevention. What will the future hold? Well, there are a number of other formats, formulations, and products in development for delivery of antiretrovirals for both treatment and prevention. And that includes microneedle patches, which can be administered transdermally, newer implant technologies that may be better tolerated and release drug over a longer period of time, bioerodible implants that would not require surgical removal when the implant has given up all of its drug, combination technologies, for example, vaginal rings delivering both antiretrovirals for the prevention of HIV and hormonal contraceptives for the prevention of pregnancy, gastric reservoirs that could be given orally and deliver antiretroviral drugs over a period of weeks to perhaps up to a month. And finally, formulations that would allow reduction of the injection volume for drugs like Kabbategravir and rilpivirine. So I want to thank those who contributed to the slides and the data that I shared with you today. Some of it is still unpublished, although it's all been presented at international conferences. I also want to acknowledge my funding sources. And I also want to refer you to the website for the long-acting and extended release antiretroviral research resource program, LEAP, longactinghiv.org, which is a great place to learn more about this field as it evolves. Obrigado. Thank you very much. It's great to be with you today, and I look forward to answering your questions.